Management of a patient at high risk for recurrent laryngeal nerve injury during esophagectomy. The patient is a 62-year-old gentleman found to have invasive, moderately differentiated squamous cell carcinoma of the mid-esophagus on EGD. He underwent neoadjuvant chemotherapy and radiation, as well as feeding gastrostomy tube placement preoperatively due to severe malnutrition. Based on preoperative evaluation, he was deemed a candidate for resection via McEwen esophagectomy. His pre-neoadjuvant therapy PET scan is shown here and demonstrates an FDG-avid esophageal mass in close proximity to the location of the left recurrent laryngeal nerve. The patient was then referred to otolaryngology for preoperative vocal fold assessment. On indirect laryngoscopy, both true vocal folds were functioning normally and were mobile. Based on the patient's preoperative imaging, damage to the left recurrent laryngeal nerve during esophagectomy was anticipated. After a multidisciplinary discussion, the decision was made to preemptively inject and medialize the left true vocal fold with carboxymethylcellulose gel in order to avoid respiratory complications as a result of vocal fold paralysis following esophagectomy. This gel is a temporary agent. This was successfully performed 1 week pre-esophagectomy with good medialization of the left true vocal fold post-injection. The patient then underwent McEwen esophagectomy with thoracoscopic mobilization, open abdominal portion, and cervical esophagogastric anastomosis. There was treatment effect from radiation with associated surrounding fibrosis. The dissection was carried out directly onto the esophagus above the azygos vein in order to avoid damage to the recurrent laryngeal nerve. Postoperatively, the patient was noted to be hoarse but had a good cough and had excellent pulmonary toilet. He had no postoperative respiratory complications. Otolaryngology was consulted during this immediate postoperative admission for indirect laryngoscopy to assess vocal fold function. Indirect laryngoscopy was performed. In the following video, the left true vocal fold is located on the right side of the screen. The indirect laryngoscopy showed excellent apposition of the true vocal folds. Following an esophagram that demonstrated no anastomotic leak, a video fluoroscopic swallow study was performed that showed subtle aspiration with thin liquids. The patient then underwent speech therapy evaluation and treatment, including education on safe swallowing exercises. However, his diet was not advanced during hospital admission. The patient was discharged with NPO orders and J-tube feeds. The patient underwent repeat indirect laryngoscopy 1 month postoperatively, which demonstrated findings consistent with permanent left true vocal fold paralysis. Injection with calcium hydroxylapatite gel, which is a semi-permanent agent, was therefore performed. The patient will return for indirect laryngoscopy in clinic every 4 months for 1 year postoperatively, at which point a thyroplasty will be considered. Repeat outpatient video fluoroscopic swallow study following injection of the semi-permanent agent demonstrated improved swallowing with no aspiration with thin liquids. His diet was subsequently advanced. In conclusion, preoperative true vocal fold injection has the potential to lessen the respiratory complications of recurrent laryngeal nerve injury post-esophagectomy and should be considered in patients deemed high risk for recurrent laryngeal nerve injury during esophagectomy based on preoperative imaging. Otolaryngology and speech therapy are important parts of a multidisciplinary approach to the management of patients undergoing esophagectomy.